Introduction. This article presents a case of a fatal disseminated neosporosis in a 3-month-old cane Corso puppy. Neospora caninum is a protozoal parasite that has a 2-host life cycle, with canids as definitive hosts who shed oocysts in their feces, and cattle and other ruminants serving as primary intermediate hosts. The parasite's life cycle is complex and not completely understood. Oocysts sporulate in the environment and are ingested by intermediate hosts where they release sporozoites and bradyzoites, which then convert into tachyzoites, replicate, and disseminate into tissues including the uterus. As host immunity develops, tachyzoites convert back to bradyzoites, and encyst mainly in neural tissue and skeletal muscle. Dogs can become infected by ingesting these cysts in raw or undercooked meat, or aborted fetal material. Although dogs are primarily definitive hosts, they can also serve as aberrant intermediate hosts, especially in cases of congenital infection. Congenital infections occur when puppies are born to dams that were infected during pregnancy, or when a chronic infection is reactivated in seropositive dams. While clinical disease from N. caninum infection is rare in immunocompetent adult dogs and cattle, in dogs, congenital infection results in puppies that appear healthy at birth with cysts and tachyzoites mainly in the brain, spinal cord, and muscle. Clinical signs commonly appear between 3 and 9 weeks of age, as tachyzoites continue to replicate and the immune response develops, which leads to increased tissue damage. Affected puppies often exhibit weakness, rigidity, and paralysis, usually starting in the hind limbs and progressing to the forelimbs, neck, and eventually dysphagia and death if not treated. Other manifestations may include megaesophagus, myocarditis, respiratory disease, and skeletal muscle fibrosis. Therefore, prompt diagnosis is critical because congenital neosporosis is often fatal if untreated. Definitive antemortem diagnosis is achieved through PCR of cerebrospinal fluid, CSF, or affected tissues, though organisms may be visualized using immunohistochemistry. Sensitivity of this method is low. In puppies with clinical signs of myositis or paralysis, a presumptive diagnosis may be made if IgG antibody titers against N. caninum are positive, though clinically unaffected puppies may also have positive titers. Early recognition, diagnosis, and treatment are crucial for survival. Delayed treatment is associated with a poor prognosis. This case report highlights a fatal case of disseminated neosporosis in a young puppy, emphasizing the need for clinicians to recognize the symptoms of this disease. Study design. This is a case report describing a 3-month-old cane Corso puppy that presented to the Purdue Veterinary Hospital Emergency Service with a 1-week history of progressive left hind limb lameness. The puppy's condition rapidly deteriorated, leading to a comprehensive diagnostic investigation, and eventually, a necropsy. This case report details the clinical findings, diagnostic procedures, and post-mortem results to provide a comprehensive picture of disseminated neosporosis. The data collected included clinical observations, blood work results, magnetic resonance imaging findings, cerebrospinal fluid analysis, serological tests, gross necropsy findings, histopathological analysis, and polymerase chain reaction test results. All the data was collected during the course of treatment and diagnostic procedures that were conducted as part of standard of care. Results. The puppy was presented with a 1-week history of difficulty using the left hind limb after receiving a vaccination. At initial presentation, the puppy was quiet but alert and responsive, with non-ambulatory paraparesis and proprioceptive ataxia, more pronounced in the left hind limb. The puppy lacked pelvic limb reflexes and a perineal reflex, localizing the issue to the L4-S3 spinal cord segments. 2 days later, the condition progressed to non-ambulatory tetraparesis, with reduced reflexes in the thoracic limbs and absent reflexes in the pelvic limbs. The puppy also exhibited a dull mentation, reduced to absent nasal sensation, and an absent gag reflex. The cutaneous truncee reflex was absent caudal to L1. Blood work revealed eosinophilia with a count of 2.02 K/L, reference interval 0.10 to 1.25 K/L. The chemistry panel showed an elevated alanine aminotransferase, ALT, level of 878 U/L, reference interval 3 to 69 U/L, and a markedly elevated creatine kinase, CK, level of 36,000 U/L, reference interval 22 to 491 U/L. MRI revealed multifocal, diffuse T2-weighted hyperintensities and heterogeneous contrast enhancement in the apaxial muscles and muscles of the head. The CSF analysis revealed an elevated protein level of 212 mg per deciliter, reference interval less than 25 mg per deciliter, and a total nucleated cell count of 102 cells/L, reference interval 5 cells/L, with 62% neutrophils. Extensive testing was performed to rule out infectious diseases. Serology using enzyme-linked immunosorbent assay, ELISA, was negative for Diarrhea immitis, Ehrlichia canis, E. Ewengii, Borrelia burgdorferi, Anaplasma phagocytophilum, Na. Platies. Enzyme immunoassay, EIA, for blastomyces dermatitis urine antigen was negative. Immunofluorescent antibody tests, IFAT, were negative for Ehrlichia canis, Rickettsia rickettsii, Borrelia burgdorferi, Babesia canis, and Cryptococcus neoformans. The antibody titers returned positive for IgG against Neospora caninum, with an IFAT dilution titer of 1:4096, baseline 132. All other antibody titers and antemortem infectious disease tests were negative. Due to the rapid progression of the clinical signs, the puppy was started on broad-spectrum antimicrobials, clindamycin and trimethoprim/sulfamethoxazole, TMS, as well as dexamethasone and gabapentin to manage inflammation and pain. The puppy experienced cardiac arrest 2 days after diagnostic testing was performed, and the body was submitted for necropsy. At necropsy, the skeletal muscle of all 4 limbs was pale tan and slightly firm. Pale tan to white streaks were observed in the muscles of the diaphragm, abdominal wall, and myocardium. The brain and spinal cord were grossly unremarkable. Histological examination showed that cardiomyocytes and myocytes in multiple skeletal muscles were frequently degenerative and necrotic. There was an abundant presence of inflammatory cells, including lymphocytes, macrophages, and degenerate eosinophils and neutrophils, dissecting between and replacing degenerating myocytes. Rare, approximately 22 m diameter, round basophilic structures containing numerous 1 to 2 m, round, distinct basophilic bradyzoites, protozoal cysts, were identified in skeletal myocytes. In the spinal cord, especially the lumbar segment, Gitter cells and neutrophils infiltrated the white matter. Many myelin sheaths were dilated, containing swollen axons, and sometimes fragmented or absent axons, and replaced by Gitter cells. Similar changes were observed in the white matter of the hippocampus, along with an expansion of the Virchow-Robin space. A few degenerating protozoal cysts were identified in the areas of neuronal inflammation. Real-time polymerase chain reaction performed on formalin-fixed, paraffin-embedded sections of the skeletal muscle and brain was positive for Neospora caninum with a CT value of 22.09. Figure 1 shows parasagittal and transverse magnetic resonance images of the lumbar spine. The T2-weighted images display hyperintense regions within the lumbar apaxial musculature, indicated by a red arrow. The T1-weighted post-contrast images show heterogeneous contrast enhancement, indicated by a yellow star. Figure 2 shows gross photographs of the body wall, diaphragm, and heart. In panel A, skeletal muscle is firm with multifocal to coalescing pale tan to white streaks, white arrowhead, and shows the diaphragm, black arrowhead. Panel B shows the heart with multiple pale tan streaks visible on the epicardial surface, black arrowhead, and the cut section of the ventricular wall is mottled tan, white arrowhead. Figure 3 includes photomicrographs of skeletal muscle. In panel A, myocytes are separated by increased clear space, with inflammatory cells, arrowheads, primarily lymphocytes, and a few neutrophils. The sarcoplasm is fragmented with loss of definition and necrosis of some fibers. Panel B shows a non-degenerate protozoal cyst containing numerous bradyzoites within the sarcoplasm of one myocyte, arrowhead. Figure 4 includes photomicrographs of the cerebrum. Panel A shows focal white matter inflammation at the level of the hippocampus, with marked gliosis. Virchow-Robin spaces are expanded by lymphocytes, plasma cells, and macrophages, arrowheads. Panel B shows a few degenerate protozoal cysts with eosinophilic bradyzoites in the affected white matter, arrowheads. Discussion. The necrotizing myositis, myocarditis, and encephalomyelitis, along with intralesional protozoal cysts, are consistent with disseminated protozoal infection, with the cysts being consistent with either Neospora caninum or Toxoplasma gondii. The positive IgG titers for Neospora caninum, along with the negative Toxoplasma gondii titer and positive Neospora caninum PCR results, confirm that the infection is indeed due to Neospora caninum. While clinically unaffected puppies can have positive IgG titers for Neospora caninum, clinically affected puppies tend to have high titers. In a study of 12 dogs, the titers in unaffected siblings ranged from 140 to 1:640, while the clinically affected sibling had a titer of 1:50-120. The asymmetric paresis, lameness, and progression to cranial nerve deficits are not typical of congenital Neospora infections. The rapid progression of the signs and delay of treatment are associated with poor prognosis in disseminated neosporosis. Mild to moderately elevated serum creatine kinase levels are common in dogs with neosporosis. The extremely elevated CK level in this case is most likely secondary to the severe skeletal muscle involvement. The diffuse pallor in the skeletal and cardiac muscle correlates with the histological findings of fibrosis and inflammation from the destruction of the skeletal and cardiomyocytes. Organisms were rarely seen in the tissue, suggesting the severe myonecrosis was secondary to inflammation rather than direct destruction by the tachyzoites. The initial number of the organisms may have been obscured or destroyed by the chronic inflammation in this case. Congenital neosporosis is an important differential for hindlimb paresis in young puppies without a history of trauma. The identification of a clinically affected puppy does not necessarily indicate infection of all littermates. Puppies born to seropositive dams may sporadically develop the disease, and the dams with higher titers are more likely to transmit the infection to their puppies. Given the severity and mortality of N. caninum infections, serologic testing of littermates, and additional monitoring or treatment of seropositive animals may be indicated. Treatment with clindamycin, sulfonamides, or ponazuril, alone or in combination, may be effective, but treated animals should be assumed to be chronically infected because bradyzoites are not susceptible to treatment. Although the puppy in this case received treatment before diagnostic testing results returned, the rapid progression of the clinical signs prevented treatment efficacy evaluation. The ascending paresis with reflex deficits in a young puppy, especially with elevated creatine kinase, is a strong indication of disseminated neosporosis. Prompt treatment is crucial to improving the prognosis for recovery. Congenital transmission may not affect all puppies in a litter, but the high morbidity of this disease warrants testing and monitoring of littermates. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.